Hi friends, in this video of ECG Basic, today I will talk about inferior wall as ST elevation MI. First is the disclaimer. Caring Docs YouTube channel does not provide medical advice. Information available on this channel does not offer diagnosis or advice regarding the treatment. Information provided by this channel is for educational purpose only. It should not be used as an alternative to healthcare professionals' diagnosis or treatment of any person or animal. Please seek the help of medical expert for diagnosis, prevention, and treatment of medical illnesses. There is no endorsement for any brand or a company. The diagnostic criteria for inferior wall ST elevation MI is ST elevation in lead 2, 3, aVF. These are the inferior leads. We will see ST elevation in these leads. Hyperacute T waves may precede these changes. There may be reciprocal ST depression in AVL, progressive development of Q waves in lead 2, 3, and aVF. Inferior wall MI accounts for 40 to 50% of all MIs. It generally has more favorable prognosis than the anterior MI. That is, in hospital mortality is only 2 to 9%. However, certain associated features may indicate worse outcome, and these features are concomitant right ventricular infarction in 40% of the patient. These patients may develop severe hypotension in response to nitrate, significant bradycardia due to second or third degree AV block, posterior infarction due to extension of the infarct area. We should never neglect the lead AVL. AVL is the only lead truly reciprocal to the inferior wall, as it is only the lead facing the superior part of the ventricle. It is thus a sensitive marker for inferior infarction. In patients cohort with inferior occlusion myocardial infarction, ST depression in AVL has been shown to be more prevalent than ST elevation in the inferior leads. 91% of the subtle inferior ST elevation MIs that do not meet STEMI criteria but show occlusion on PCI demonstrates ST depression in AVL. So, the AVL carries a very high significance in inferior wall MI. Which artery is the culprit? As we know that inferior STMI can result from occlusion of any of the three main coronary arteries. First is the dominant right coronary artery in 80% of the cases, dominant left circumflex artery in 18% of the cases, occasionally a type 3 or a wrap around left anterior descending artery, producing the unusual pattern of concomitant inferior and anterior ST elevation. While both right coronary artery and left circumflex occlusion may cause infarction of the inferior wall, the precise area of infarction and thus the ECG pattern in each case is slightly different. The right coronary artery territory covers the medial part of the inferior wall, including the inferior septum. The injury current in the RCA occlusion is directed inferiorly and rightwards, producing the ST elevation in lead 3 more than the lead 2, as lead 3 is more rightward facing. The left circumflex territory covers the lateral part of the inferior wall and the left posterior basal area. The injury current in the left circumflex occlusion is directed inferiorly and leftward, producing ST elevation in the lateral leads, lead 1 and V5 V6. These differences shows the electrocardiographic differentiation between the right coronary and the left circumflex occlusion. The right coronary artery occlusion is suggested by ST elevation in lead 3 more than the lead 2, presence of reciprocal ST depression in lead 1, signs of right ventricular infarction, that is ST elevation in V1 and V4R. Circumflex occlusion is suggested by ST elevation in lead 2 equal to lead 3 Absence of reciprocal ST depression in lead 1. Signs of lateral infarction, that is ST elevation in the leads 1, later leads 1 and AVL or V5 V6. In this ECG, we can see early inferior ST elevation MI. Here we can see hyperacute, that is peaked T waves in lead 2, 3, AVF with relative loss of R wave height. Early ST elevation and Q wave formation in the lead 3. Reciprocal ST depression and T wave inversion in AVL. ST elevation in lead 3 is more than lead 2. It suggests right coronary artery occlusion. The subtle ST elevation in V4R would be consistent with this. Here we can see how the ST segment morphology in AVL is an exact mirror image of lead 3. The concept of reciprocal change can be further highlighted by taking the lead AVL and inverting it. Note here that ST morphology now looks like identical to lead 3. Inferior STMI. Here we can see ST elevation in lead 2, 3 and AVF, Q wave formation in lead 3 and AVF, reciprocal ST depression and T wave inversion in lead AVL. ST elevation in lead 2 is equal to ST elevation in lead 3 and absent reciprocal changes in lead 1, that is isoelectric ST segment. It suggests a left circumflex artery occlusion. Inferior wall ST elevation MI. Here in this ECG we can see marked ST elevation in lead 2, 3 and AVF with early Q wave formation. Reciprocal changes in the AVL can be seen. ST elevation in lead 3 is more than lead 2 with reciprocal changes present in lead 1 and ST elevation in V1, V2 suggests right coronary artery occlusion with associated right ventricular infarction, and this patient should have right-sided leads to confirm this. Hyperacute inferior ST elevation MI is shown in this ECG. Here we can see tall or hyperacute T waves in lead 2, 3 and AVF and early ST elevation and loss of R waves height in lead 2, 3 and AVF. Reciprocal changes in AVL and lead 1 can also be seen. Here in this ECG we can see the concave ST elevation in lead 2, 3 and AVF. It can be mistaken for pericarditis. However, and the fact that ST elevation is localized to the inferior lead with reciprocal changes in the AVL confirm that this is the inferior ST elevation MI. Here we can see massive inferior ST elevation MI. Here marked ST elevation in lead 2, 3 and AVF with tombstone morphology is seen. Reciprocal changes in the AVL are also present. ST elevation is also present in the later leads like V5, V6, indicating it as an extensive infarct of the inferior and the lateral walls. In the patient with inferior ST elevation MI, ST elevation of more than 2 mm or more in lead V5 and V6 is predictive of extensive coronary artery disease and large area of infarction. This ECG shows recent inferior ST elevation MI. We can see well-formed Q waves in lead 3 and AVF, suggesting that STME is not acute. The T wave in lead 3 and AVF are beginning to invert. There is still some residual ST elevation in the inferior lead, that is lead 2, 3 AVF and V5, V6 leads. ST elevation may take 2 weeks to resolve after an acute inferior MI, even longer for an anterior ST elevation MI. Note that if this patient had ongoing chest pain, we should still treat them as an acute ST elevation MI. Bradycardia and AV block in inferior ST elevation MI is also seen. Up to 20% of the patients with inferior ST elevation MI, they may develop either second or third degree AV block, and there are two presumed mechanisms for this. First is the ischemia of the AV node due to impaired blood flow by the AV nodal artery, and this artery arises from the right coronary artery, that is 80% of the time. Hence, its involvement in the inferior ST elevation MI due to right coronary artery occlusion. Then is the Bizold-Jerich reflex, that is increased vehicle tone secondary to ischemia. The conduction block may develop either as a stepwise progress from first degree heart block via Benki-Bax to complete heart block in 50% cases, or as an abrupt onset of second or third degree heart block in the remaining 50% cases. Patient may also manifest signs of sinus node dysfunction such as sinus bradycardia, sinus pauses, sinoarterial exit block, sinus arrest, and similarity to AV node dysfunction, this may result from increased vagal tone or ischemia of SA node. That is, the SA nodal artery is supplied by the RCA in 60% of the people. Bradyarrhythmias and AV block in the context of inferior ST elevation MI are usually transient. They last for hours to days and respond well to atropine, and often they don't require permanent pacing. Here we can see the inferior ST elevation MI with third degree heart block and slow junctional escape rhythm. Again, the inferior ST elevation MI with sinus node dysfunction, either sinus arrest or extreme sinus bradycardia, and slow junctional escape rhythm. The best way to find yourself is to lose yourself in the service of other. It was said by Mahatma Gandhi. With this, I conclude my today's topic on inferior wall ST elevation MI. Thank you. Keep learning.